everybody. Welcome. Before we begin, I would like to let everyone know that this session is being recorded. These recordings will become available on our DentEcho website post-session. And Taylor, if you could share the announcement slides. And we are very excited to have everyone join us for the 20th DentEcho. This session is brought to you in collaboration by the Texas Association of Community Health Centers and UT Health San Antonio. My name is Kato, and I will assist in facilitating today's session. Next slide. And here is our agenda for today. We'll start off with some announcements and introductions, then move on to didactic and case presentation by Dr. Gonzalez, with time for Q&A at the end. And some notes before we get started. Next slide. These sessions are recorded for later distribution on our DentEcho website. Please stay muted unless you are speaking. You can also use the chat to raise questions and share your perspectives. The slides and recordings will be made available on our DentEcho website post-session. To help us with attendance, please enter your name, affiliation, and email into the chat. Please remember that no personal health information is allowed in either the chat or our discussions. If you would like any assistance with your connection throughout the session, please chat Taylor or DentEcho IT. Next slide. And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. ECHO is an all-teach, all-learn supportive model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. We also encourage you to join by video if you can. Next slide. And to receive CDE CME credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, make sure to register through SMILE, which you can do so now using the link in the chat or by scanning the QR code. When registering, please use the supercode ECHO 2024. And thank you, Taylor. Please unshare the slides. And let's do some introductions. Dr. Chala.
Thank you, Kito. And thank you all for taking the time to come here. And I'm Suman Chala. I'm the PI of the grant that supports this program. And we're delighted to have you all here. And thank you, Dr. Gonzalez, for being here.
Dr. Marwaha.
Hi, good afternoon, everybody. Welcome to the 20th DentEcho session. I'm glad you're all able to join this. Thank you.
Kathleen.
Good afternoon. Thank you for joining us. My name is Kathleen Weeks, and I'm here as the project coordinator for the ECHO.
And is Dr. Rankar on? Yeah, not yet. All right, perfect. I will now pass the mic over to Dr. Dar to introduce herself and also today's speaker, Dr. Gonzalez. Dr. Dar, you might be muted. You might be muted. Perfect.
Thank you so much, Ms. Kawasaki. I'm Shohini Thar, and I work as a part of the DentEcho Hub. It is my absolute pleasure to introduce Dr. Gonzalez today. Dr. Cara Gonzalez is a tenured associate professor in the Department of Comprehensive Dentistry at our school. She is also co-director of the CoStar DDS PhD track program and also serves as the co-director for the Oral Cancer Working Group at Mays Cancer Center. She has a dual degree, DDS PhD, from our institute, and she graduated in 2003. In 2008, she completed a 2-year combined Veterans Administration Research Fellowship with a focus on oral cancer and an AAGD program here at our school. During her residency, she was awarded first place in the Special Care Dentistry Poster Competition on treating kids with HIV. Her phenomenal work with her residency program has resulted in publication in general dentistry and is the focus of today's DentEcho session today. welcome, Dr. Gonzalez. I have attended your presentations before, and I look forward to yet another wonderful and informative presentation. Thank you from all of us.
Thank you for having me. Let me see if I can share my screen here. Can y'all see that okay?
Looks great.
Okay. No, I'm truly honored to be invited to give this presentation. And so, as you know, I'm going to be talking about the differences in treating kids versus adults with HIV. And Dr. Dar already mentioned that this came from my residency way back when in the AGD program at the Health Science Center. And through that program, we saw a lot of HIV positive patients. They were supported by the Ryan White grant. But most of these patients were adults. And so we had one 13-year-old that was going to be coming in. And so while he had an adult dentition, we didn't know if there might be modifications that might need to be made in providing his care because of his age. And so this is a summary of all the findings when I searched the literature and gathered information to see what we needed to look out for when providing care to this child. And I've updated this presentation throughout the years as I've given it to the pediatric dentistry residents. So my hope is that this will be interactive, although I know sometimes in a Teams or Zoom meeting, it's hard to just chime in, but I want you to feel free to interrupt me. And if you have questions or if you have a personal experience, please share it with the group, because as you'll hear from the presentation, there are not a lot of kids living in the United States with HIV, not anymore. So this is something we don't run into very frequently. So I hope you will share your experiences. And I also hope that this can serve as a resource for you if you do come across one of these kiddos. All right, so I'm going to start by giving you a little background on the AIDS epidemic. So this began in 1981, and it may have started even before then, and we just weren't aware of it yet. But there were several cases of a rare lung infection called pneumocystis carinii pneumonia, or PCP. This was found in 5 young, previously healthy gay men in Los Angeles. And there were also separate reports of a group of men in New York and in California that had unusually aggressive cancers called Kaposi sarcoma. Now, all of these men were found to be immunosuppressed. And while we didn't know the cause of their immunosuppression, it became evident that this was a contagious disease. And in fact, by the year's end, there were 337 cases of severe immunodeficiency, including 16 in children under the age of 13. It wasn't until 1984 that we identified the virus that causes AIDS, human immunodeficiency virus, or HIV. We're all aware of it. And then the first antiretroviral drug was approved in 1987 by the FDA for use in adults. And it wasn't until 1990 that it was approved for use in children. So this sounds great. We already have a drug, right? Except it wasn't a great drug. It didn't really lower the death rates all that much. And so by 1992, AIDS became the #1 killer of men aged 25 to 44. And in fact, by 1993, there were 300,000 cases of AIDS reported in the United States. So looking at this graph, we see this steep increase in people classified as having AIDS and dying from AIDS. And then we see it sort of drops off here when the CDC implemented an actual strict definition for AIDS. And the reason for this drop off is prior to the definition, or 1993, people who had AIDS-associated diseases, if we didn't know their T-cell count, they were classified as having AIDS, along with people whose T-cell counts we did know were low. And so they were all kind of lumped together. And just because you have an AIDS-associated disease doesn't necessarily mean you have HIV. And so when they implemented this definition, we saw a drop-off in the number of people classified as dying from HIV or AIDS. But it wasn't till 1996 where we see a really steep decrease in the number of deaths. And this is with the implementation of HAART, which is highly active antiretroviral therapy. And this is wonderful. So these are antiviral drugs, and it's not that singular drug that was previously used, but this is a combination of 2 or more drugs that more effectively inhibit the HIV virus from replicating. So this is wonderful because it turned this AIDS epidemic, where everyone was dying, into more of a chronic disease, as you can see here. What is unfortunate is the prevalence continued to climb, and it's somewhat leveled off now at about 550,000 people with HIV in the United States as of 2021. What's also interesting is a lot of these new diagnoses vary across region, with the South having the highest number of cases. So if you're practicing in Texas, you have a higher probability of treating a patient that has HIV. And then this is followed by the West, then the Northeast, and the Midwest has the lowest number of new diagnoses. And these are due primarily to male sexual contact, makes up 68% of the people who are diagnosed with HIV, followed by heterosexual contact, IV drug abuse, and then a combination of male-to-male sexual contact and IV drug abuse. When we look at differences amongst race and ethnicity, we see that African Americans are most affected by HIV. And we really need to figure out why this is, because they are a minority in the US population, and yet they make up the majority of new diagnoses. So this is where we need our epidemiologists and our public health people to come in and figure out why this patient population is more affected. And it's really important because you can see their death rate is also much higher than other races and ethnicities. Do y'all have any questions for me so far? If you do, just chime in. So now I'm going to give you a little bit of the background on HIV in children. So in 1999, the CDC estimated there were 10,000 perinatally HIV-infected children in the US. And these kiddos acquired the virus either in utero, at birth, or from their mother's breast milk. However, by 2006, with the implementation of antiretroviral drugs given to the mother during pregnancy or to the child post-delivery, we saw a reduction of the 25% perinatal transmission down to 8%. So this is great. The rates of children living with HIV have steadily declined due to the dramatic reduction in perinatally acquired HIV. And in fact, by 2021, there were only 1,266 children under the age of 13 living with HIV and AIDS. But if you look at this map, you can see that the South still has the highest rates of children being diagnosed with HIV, while overall they're relatively low. Florida has the highest rate, followed by some other southern states, and then Texas has also got a relatively high rate, with 2.2 children per 100,000 population being diagnosed. What's interesting is if you look at perinatally acquired HIV, Texas is the #1 state, and this is not something you want to be #1 in for perinatally acquired HIV. So there were only 36 cases in the United States, but 6 of them were in Texas. Now, this is not entirely shocking when you consider that Texas has the highest maternal death rate in the country. In fact, it's twice as high as the second highest. So we have over, I think it was like 400 per 100,000 versus the next state, which I think was Florida, was around 200. So we need to figure out what's going on with our access to care for pregnant women, both during their pregnancy and postpartum. And once again, it's the African American population that's disproportionately affected. So these children make up 14% of the children population, and yet they make up 57% of new diagnoses of HIV. I'm going to switch gears now and talk a little bit about the different stages of HIV infection. So I want to point out stage 0 is the earliest stage when someone is first becoming ill and have not yet elicited an immune response. Whereas stage 3 is where CD4 T cells drop below 200 and is considered full-blown AIDS. And so we used to diagnose what stage a patient was at based on their CD4 T cell count and their clinical status. And so what I mean by clinical status is they had, or we do have, a list of AIDS defining conditions, which I'll show you in a few minutes. And so if we see a drop in the CD4 T cell count, or we see that they're getting ill with one of these AIDS defining conditions, then that's how they were staged. You could not identify people who had stage 0 using this method. But we now have more sensitive tests where we can actually test for the virus. And so RT-PCR measures HIV RNA or the DNA that's reverse transcribed. And this is the most sensitive test, followed by an HIV antibody or antigen test. But this test requires that the patient has been ill long enough to elicit an immune response. So if someone is being newly diagnosed with HIV, the combination of these two tests enables you to identify stage 0 because they will be positive for the virus and negative for antibodies. Now, alternatively, we have newborns that may test positive for antibodies, and they may have gotten them from their mother, and then later they may test negative for antibodies. Our diagnoses now require an HIV positive laboratory test, meaning using the RT-PCR analysis. And this is especially for CDC surveillance purposes. So it lets you know if you have the virus. But in practice, if a person is negative for the antibody and positive for the virus, then you've caught them at stage 0, which is great. Because this is when the viral load is at its highest. So the person is the most infectious right now, and they might not even know they have HIV. And so they could be spreading it, right? But it also enables early intervention with heart therapy so that they can stay healthy and not see a drop in their CD4 T cell counts. Do y'all have any questions over that? Okay, now another way to know if someone's at stage 0 is if they test negative for an antibody test, and then within 6 months, they test positive. So you know you've caught them within that range. But after 6 months, the patient will have antibodies. And so stage 1 and stage 2 are determined by their CD4 T lymphocyte count. Now, I want to point out this is a key difference in adults versus children. In adults, we use the absolute count for the CD4 positive T cells, and in the children, we use their percentage. The reason for this is as kids mature and grow, the number of CD4 positive T cells will vary with age. And so a percentage is easier to follow their disease progression than trying to remember the changes in the values over time. I also want to point out that even if your CD4 T cell count isn't very low, if you have what's called an AIDS defining condition, then you are automatically upstage to stage 3, regardless of the T cell count. So here's a list of the AIDS defining conditions for adults. There's a whole slew of them, but these don't hold true for children. In children under the age of 6, AIDS defining conditions are when they start to get multiple and recurrent bacterial infections. It lets them know that their disease is progressing. I like this chart because it shows how you use the percentage in kids and why. So notice they refer to the stages as category 1, 2, and 3. But in most literature, you'll see it written as stage 1, 2, and 3. But see how over time, so from 0 to 12 months, their CD4 positive T lymphocyte count is over 1,500. Then from 1 to 5 years of age, it's over 1,000, and 6 to 12, it's over 500. And so rather than memorizing all these numbers, if we know that their CD4 positive T cell count is is less than 40, but greater than 25, then they are in stage 1 of the disease. So I failed to mention that a healthy person will have a 40% CD4 positive T cell count. So anywhere between 40 and 25% will make up stage 1 disease. And at this stage, they are not considered immunosuppressed. Now, if it drops down between 15 and 24%, this is then stage 2, and they are moderately immunosuppressed. And if it drops below 15%, these kids are classified as stage 3, and they are severely immunosuppressed and classified as having AIDS. And the reason this is important is because people with stage 2 or stage 3 disease are at risk of opportunistic infections, and so they're going to require antibiotic prophylaxis prior to dental treatment. Another thing to note is that you also need to know not only their current CD4 T cell count or percent, but the history of their CD4 T cell count. Because if their count has ever dropped below 15% for kids or 200 for adults, they are then classified as having AIDS. And even if with therapy, the CD4 T cell count goes back up, they will still always be classified as having AIDS, and they will always require antibiotic prophylaxis. So you need to have a really good history from these patients. Now, we're all familiar with the antibiotic prophylaxis regimen. So the only thing I really want to remind you of is that we no longer use clindamycin because of the risk of developing Clostridium difficile. I'm going to talk now about the HIV viral load. This is another key difference between adults versus kids with HIV. So in adults with HIV, you can follow their viral load to see how well their disease is being managed. And this is done, again, using the RT-PCR test. And if their viral load is less than 400, it's considered undetectable. The virus is still present, it's just not within a detectable range, and it shows you their disease is well managed and they're less contagious. However, in children under 13, there are no normal values defined for viral load. So you can't look at these numbers to sort of make an assessment of how well they're doing. Now, I like this cartoon of the HIV life cycle because it shows us all the different stages which we've taken advantage of to develop drugs to target HIV. And so I'll just remind you that this is an RNA virus. It first has to enter the cell, and it does so by interacting with the CD4 receptor, as well as 2 co-receptors, the CCR5 or CXCR4 receptor. And so we have drugs that target this called entry inhibitors. Once it's in the cell, the RNA is reverse transcribed into DNA. And so this is done by reverse transcriptase, and we also have drugs that target this. The DNA then enters the nucleus and integrates into the genome, where it's later translated into mRNA. And to integrate, it uses an enzyme called integrase. Clever name, right? So we have drugs that target the integrase as well. Once it's transcribed into mRNA, it exits the nucleus and is translated to protein, where it has to be cleaved in order to be packaged and make a new virus. And so proteases cut up these proteins for packaging. So we are probably very familiar with protease inhibitors that are used in these patients. In fact, there are about 11 classes of antiretroviral drugs with 46 drugs that are FDA approved on the market, and it's ever increasing. So it's really important that we always look up these drugs and look at their adverse side effects and interactions, because there's so many new ones coming in, can't possibly keep track of all of them. We want to make sure that we're being safe when we're providing care. So there are 11 somewhat classes. They keep adding new ones to this. But the main ones are the nucleoside and nucleotide reverse transcriptase inhibitors. These basically stop DNA synthesis because they can't form a proper bond within the DNA helix. And then we also have non-nucleoside reverse transcriptase inhibitors that inhibit HIV reverse transcriptase activity, which I was talking about right here. And of course, the protease inhibitors, there are fusion inhibitors that block the virus from being able to fuse with the membrane, integrase inhibitors, and then these are some newer ones that I'm personally not as familiar with. Capsid inhibitors, which block the formation of the capsid itself. And then they have attachment and post-attachment inhibitors, as well as a specific entry inhibitor that targets the CCR5 co-receptor. And then there are other drugs that enhance the pharmacokinetics of these. So that's a lot of different types of drugs, and patients will be on a regimen that combines 2 or more of these medications. So we have to really make ourselves aware of the potential adverse side effects and the drug-drug interactions.
Dr. Gonzalez, there's a question
Yes.
from James. Do
Yes.
you need antibiotics prior to dental treatment for children or adults or both?
It's both depending on what stage they are. So if they're stage 2 or 3, yes, you will need that. Thank you. All right, so I'm going to talk a little bit about drug-drug interactions. A really common drug is the protease inhibitor ritonavir. It's also called Norvir. And this drug, it's metabolized by cytochrome P450, the isoform 3A4. So we refer to that as CYP3A4. But it's also a potent inhibitor of CYP3A4. So if you have other drugs that need to be metabolized by this isoform, they're not going to be, and you will get a buildup of those drugs in the system if your patient is on this protease inhibitor. So for example, midazolam and triazolam are both metabolized by CYP3A4. And so it is strictly contraindicated to give these drugs with patients on ritonavir because you can get an increase in the sedative effect and cause respiratory depression in these patients. Now, this drug can be prescribed alone or in combination with lopinavir in a drug called Kaletra. And again, this is why we have to look all these up because they're ever changing. Another drug that is contraindicated is Demerol, and it's contraindicated in patients on these protease inhibitors. It should not be used because it's metabolized by CYPs2B, 3A4, and 2C19.2. And so if patients are on a protease inhibitor, they're going to get increased plasma concentrations of Demerol as well as its active metabolite normapyridine, and they can get respiratory depression. So diazepam is what's recommended for stress management in HIV-infected patients. It's metabolized by the CYP2C19, which is less frequently used by other drugs. Another class of drugs to be aware of are the azole antifungals. So HIV patients are very prone to getting candidiasis. And so you will probably need to prescribe them something if they have candidiasis in the mouth or in the corners of the mouth. But these azole antifungals are competitive inhibitors of CYP3A4 also. Ketoconazole is the most potent inhibitor, followed by itraconazole and then fluconazole. Ketoconazole is shown to have significant interactions with non-nucleotide reverse transcriptase inhibitors, and so co-administration is not advised. It can also increase the amount of protease inhibitor concentrations in the blood anywhere from 30 to 130%, and vice versa. If they're already on the protease inhibitor, when you give them ketoconazole, you can see increased levels of ketoconazole as well. And so fluconazole is what should be prescribed if you're going to give someone a systemic antifungal medication. Also, Nystatin and Troches can be prescribed as they're not metabolized by the liver. Okay, I'm going to talk now about some of the side effects of the highly active antiretroviral therapy. There are quite a few. Importantly, protease inhibitors are toxic to the liver, especially in patients who are co-infected with hepatitis B or C. And so it's important that you have current liver function tests on your patients within the last 3 months. And often they know this and they'll show up to your office with this information in hand. If not, you can request it and get it from their doctors before you actually do any treatment. But if you see an increase in these enzymes, ALT, AST, and ALP, that's indicative of liver toxicity. And so they're going to be more susceptible to an opportunistic infection and will require antibiotic prophylaxis. This is true even if they're still in stage 1 of the disease. Now, sometimes you will see hyperbilirubinemia in these HIV positive patients. It is not considered indicative of hepatic injury, even in jaundice patients. So we don't need to necessarily prescribe antibiotics if their bilirubin is high, as long as these enzymes are within a normal range. Now, these medications can also induce neutropenia, which places these patients at increased risk for infections. So you need to, if you're going to do any kind of really invasive procedures, you need to order a complete blood count or CBC with differential. And the with differential is very important because this is what's going to give you your absolute neutrophil count and let you know if you need antibiotic prophylaxis. So the CBC will show you the total white blood cells, and the differential will show you the breakdown. You'll also see red blood cells and platelets. But within the white blood cells, we have lymphocytes, neutrophils, basophils, eosinophils, and monocytes. And again, it's the neutrophils we're most interested in with the ANC. So this is calculated by taking the total number of white blood cells and multiplying it by the percent of segmented neutrophils. The segmented neutrophils are mature neutrophils, and they're shown here in panel A. You can see that their nucleus has segments, so they're called segs. And then also plus the percent of banded neutrophils. These are immature neutrophils, and you can see their nucleus is a single band. And so the ANC is going to determine your risk for infection. So this shows you your normal value. Patients with mild neutropenia will have between 1,000 and 1,500 cells per cubic millimeter of blood. Moderate is between 500 and 1,000, and then severe is less than 500. And so if your patients have more than 2,000, then no antibiotic prophylaxis is needed. If it drops between 1,000 and 2,000, then you would want to provide antibiotic prophylaxis before you do any really invasive procedures. But even if you're just doing something that you might not consider that invasive, like scaling or root planing, you would need this. Now, patients that are severely neutropenic will need to be seen in the hospital where they can be given IV antibiotics. Okay, other side effects include thrombocytopenia or idiopathic thrombocytopenia purpura. And so basically, this is when the platelet cell count drops. And so if the platelet count is greater than 75,000 per cubic millimeter of blood, no support is needed for these patients. If their count is between 40,000 and 70,000, then you can manage any bleeding with local hemostasis measures, which you're all very aware of, but they include pressure, topical thrombin, microfibrillar collagen, and primary closure. If their platelets drop below 40,000, again, they'll probably be treated in a hospital, and they would need to be transfused with patients 1 hour before the procedure, with the goal of raising their count above 50,000. And so just for your information, 1 unit of platelets is going to raise the count by an average of 10,000. Finally, some other adverse systemic effects of these medications that might be surprising to you include hyperglycemia, as well as dyslipidemia associated with metabolic syndrome. And that sounds like half of our patient population already in San Antonio, and they don't have HIV. So these drugs can cause increased sugar levels, and they can also cause abdominal obesity. They can cause insulin resistance or glucose intolerance. You'll see changes in the fat distribution in their body. So they'll have the abdominal obesity, but then peripheral subcutaneous fat atrophy. They also will have high triglycerides, low HDL, and high LDL in the blood. So they can get plaque formations, and they're at a risk of having hypertension or having a stroke if one of these breaks free. Many of them will have high blood pressure, and they'll also be in a prothrombotic state because they'll have high fibrinogen and plasmic activator inhibitor 1 in the blood. So these patients are at risk of having a stroke, and they're in a pro-inflammatory state. So you've probably heard of C-reactive protein, and these are elevated and make you at a higher risk for a cardiovascular event or heart attack. So if you're going to treat a patient with HIV in your office, these are the tests that you would want to see. Now, I say test to order. It's really like a test to request because usually these patients' physicians will provide this information to you. And they usually will come in with it in hand if they've gone to the dentist before. So you need a current CD4 T lymphocyte count or percentage within the last 3 months. You also need to know the HIV viral load within the last 3 months. Now, this is more relevant for adult patients because, like I said before, you can sort of monitor their disease progression based on their viral load, and then a current liver function test. And lastly, a CBC with differential, so you get your absolute neutrophil count and your platelet count. Do y'all have any questions over that? Okay.
Definitely. There is one comment from Hannah regarding the antibiotic prophylaxis. I have attended other lectures that base the antibiotic prophylaxis on the ANC and not basing the decision on CD4 alone. It's just a point. It's a comment.
I'm sorry, I couldn't understand what you said. What?
It's a comment from Hannah. It's not a question, but she said that regarding the antibiotic prophylaxis. She's attended other lectures that base the antibiotic prophylaxis on the ANC and not basing the decision on CD4 alone.
Okay, well, it's only if the CD4 has substantially dropped that you would want to use antibiotic prophylaxis. So it's an either or thing. Let's say your CD4 count is normal, but your ANC is low, you're going to need it. Or if your CD4 is super low and your ANC is fine, you're still going to need it. I don't know if you've heard something different, but that's what's in the literature. So I'm going to go over some of the oral manifestations of HIV that are very common in children, and then go through some that are less common and then rare in children, but common in adults. If any of you have dealt with HIV positive kids that have these oral manifestations, please feel free to chime in and tell us about your experiences. So this is the list of the common oral manifestations here. And then these are the less common, and I'm going to go through each one of these. And then the rare oral manifestations in kids that are commonly seen in HIV positive adults. So the first one is candidiasis, and this is in fact the most common oral lesion in children with HIV. So it affects up to 72% of HIV infected children. But what's interesting is its prevalence is not statistically proportional to their CD4 T cell counts as seen in adults. And what I mean by that is in adults with HIV, when their CD4 T cell counts drop, that's when they tend to start developing candidiasis. But once you treat them for the candidiasis, and also if they're on the antiretroviral therapy, they will bounce back from this infection unless it's gone into the esophagus or become systemic. In those cases, it becomes very difficult to treat. However, in children, even if their CD4 T cell counts don't drop, they're still prone to getting candidiasis in the mouth and as well as the esophagus. And this is actually associated with disease progression and a more rapid rate of progression to death. And these kids are usually treated in the hospital where they can get aggressive therapy. But the median time to death following this diagnosis is 3.4 years. So if it's a mild case, you could try topical applications of nystatin or clotrimazole initially. But these kids will usually need a systemic antifungal. And again, fluconazole is the safest. Depending on what medications they're taking, they might be able to take ketoconazole as well. But fluconazole is recommended for children that have had greater than 2 episodes or history of esophageal candida. And again, this is so that you can prevent this infection from becoming systemic.
Dr.
Yes?
Nichols, he might have a question. I see a hi. So just, would you like to unmute and ask the question if you have any?
Okay.
If not,
Well,
that's
feel free to
okay.
interrupt.
Sorry about
I'm-
that. Thank
I'm
you.
talking to my computer right now.
Yeah, feel free to raise your hand, type any
Yeah.
questions in the chat. Thank you. So you can go.
Okay, the next one that's interesting is parotid enlargement. So this affects 1 to 10% of HIV infected children. These tend to be bilateral and non-tender, and they're considered a soft indicator of HIV in children. So if a child comes into your practice who's never been diagnosed with HIV and they have this bilateral non-tender parotid enlargement, that should raise a red flag that you might want to investigate for HIV. Now, a lot of parents are foregoing childhood vaccinations now. So mumps is becoming more frequently seen in the United States. Now, those can be bilateral, but they tend to be unilateral. So again, and this can be unilateral, but if you have a child coming in where it's not tender and it's bilateral, you might want to consider testing them. And they may have a parent that's HIV positive. That's frequently seen. So this parotid enlargement occurs a little bit later in the course of the disease at stage 2, but it actually correlates with a slower progression of the disease with a median time to death of 5.4 years. And I know this is an older reference, but I've gone through and done lit searches and read what's in the literature now, and they have validated this statement and also reference back to this paper. So I haven't seen any changes in the statistics on that. This parotid enlargement is associated with lymphoid interstitial pneumonitis. What this is a rare lung disease where the lymphocytes infiltrate the lungs and they cause inflammation and fibrosis. The reason for the parotid enlargement is due to active replication of the virus, and it represents a form of lymphoid hyperplasia. So they've found in more recent studies that these have lots of, believe it or not, CD8 positive lymphocytes. Usually this is left untreated and it will improve once the patient starts their antiretroviral therapy. But rarely the physicians will prescribe anti-inflammatory agents, analgesics, antibiotics, or steroids. Now, we're all probably familiar with angular cheilitis because of our denture patients. They get this a lot, don't they? But these kiddos get this as well. It's a candida infection at the corner of the mouth. It's often concurrent with intraoral candidiasis, and you see these linear red lesions at the corner of the mouth, and they tend to be bilateral, and on the perioral skin, you'll see papules as well. They're slow to heal. In fact, they usually don't heal. They kind of go through these cycles of getting inflamed and then getting crusted over and peeling off and being inflamed again until you get proper antifungal treatment. Now, sometimes they can be co-infected with staphylococcal or streptococcal bacteria. And so the treatment is the same as for candidiasis, but you may also need some type of antibiotic as well.
Gonzalez, I'm going to jump in. So Dr. Nichols, I see your comment here. He is the dental director for the South Central ATC and see hundreds of HIV adults every month. And they only use the ANC to determine antibiotic prophylaxis, and we base this on the standards established by JADA. Sorry. We do not use the CD4 count to determine antibiotic needed.
Okay. Thank you.
Thank you.
Okay, so recurrent aphthous ulcers occur in 2 to 6% of HIV infected population, but they're more common in children. You're probably familiar with the different forms. There's major, minor, and hepatiform. Minor is less than 5 millimeters in diameter and can be covered with a pseudomembrane. Sometimes it's mistaken for candidiasis. However, it will respond to steroid therapy. The major forms are larger. They're up to 2 centimeters in diameter and they can persist for weeks. And these are very painful as well. It makes it difficult to eat. And then the herpetiform appear as clusters of tiny recurrent ulcers. They tend to be on the soft palate, the buccal mucosa, in the tonsils, and on the tongue. And so topical steroids are used, but you can also prescribe a mixture of Benadryl with kaopeptide to relieve pain and burning and facilitate eating, and then reinforce good oral hygiene. We don't completely understand what causes these, but it's believed to be possibly through autoimmune issues or hyperimmune issues. The herpes simplex virus is also common in HIV-infected children. It affects up to 24% of these kids. And they tend to have really bad cases of it and often need to be hospitalized. So as you know, it can be intraoral or perioral. It can be on the gingiva, the hard palate, the vermilion border of the lips. And initially it's vesicular, and then it ruptures and crusts over, which is what this child is experiencing here. I already said these kids tend to have really severe lesions and often require hospitalization, where they can get systemic antiviral drugs such as acyclovir. And some kids, if they have these chronic lesions that won't go away, the doctors will biopsy to look for co-infections with cytomegalovirus. Okay, and the last common oral lesion is linear gingival erythema. This is the most common form of HIV-associated periodontal disease in HIV-positive children. The prevalence really varies depending on your source. So it's anywhere from 0 to 48% of kids that are affected. The etiology is believed to be due to a unique form of candidiasis, but you'll see this 1 to 3 millimeter band of marginal gingival erythema, and often they can have petechiae. And so this erythema will persist even after a simple dental prophylaxis. So treatment includes periodontal debridement, chlorhexidine mouth rinse twice a day for 2 weeks, and improved oral hygiene. But again, it's believed to be due to Candida. So if they don't improve with that, you may consider an antifungal regimen. Okay, now I'm going to talk about less common oral manifestations. The first one is necrotizing ulcerative periodontitis. This is more common in adults than children with HIV, but you can see it in the kids. And it's a severe soft tissue necrosis with destruction of the periodontal attachment and bone over a very short period of time. Now, necrotizing ulcerative gingivitis is similar. It's characterized by destruction of the interdental papilla, but it doesn't affect the bone. And then necrotizing stomatitis is the most severe form of this disease, and it can affect the tongue, the palate, the cheeks, etc. And so again, good oral hygiene with routine prophylaxis and regular chlorhexidine rinses is recommended. But some children may also require augmentin with metronidazole if they have a co-infection. Xerostomia and xerostomia-related caries is more common in HIV-infected children than adults. So approximately 30% of all HIV-infected individuals will experience xerostomia because of their medications. And it's obviously, we're aware it's a major contributing factor to caries. And it can also contribute to oral candidiasis as well as mucosal injury and dysphagia. So it's really important that we educate our patients on good oral hygiene and also on the effects of their diet on their oral health. So again, good oral hygiene with regular exams and regular use of topical or an application of fluoride is recommended. Now, in patients with really severe xerostomia, you could prescribe pilocarpine as well, but that really needs to be managed with the patient's physician. And you need to be sure to monitor these patients for candida infections. A human papillomavirus can result in these wart-like lesions. They look cauliflower-like. They can be spiked or raised, and they are flesh-colored lesion. These are actually more prevalent in adults with HIV than children. Children that have HPV warts can also develop Verruca vulgaris, which is a really large outgrowth, or they can get widespread flat warts, or sometimes condyloma acuminate. It used to be that there was concern for sexual abuse if a child presented with this, but recent studies have shown that HPV is present in the oral cavity of children of all ages, and it's believed that it gets there by their primary caretaker, much like how bacteria colonize the mouth. And so it's not unusual to see different strains of HPV in the saliva from children at different ages, and these include the oncogenic strains and the strains that cause warts. These can be treated with surgery, laser surgery, or cryotherapy. Okay, and then varicella zoster is a primary infection with the virus. This is the virus that causes chickenpox. And then recurrent lesions are referred to as herpes zoster. And this occurs more frequently in adults. You've probably heard of shingles. It's extremely painful. But HIV-infected children are at a much higher risk for either of these. The primary varicella zoster presents as a rash. It involves the head, neck, and trunk, and it's actually that distribution that aids in the diagnosis of varicella zoster. So we know these present as vesicular, pustular, you can see, and then ultimately they will become ulcerated. But since the implementation of HAART, there's been a greater than 50% reduction in these viruses, and also if you vaccinate these children against these viruses. Okay, now I'm going to cover the two rare oral manifestations in kids that are very common in adults. So the first is oral hairy leukoplakia. So this presents as a white non-removable lesion found bilaterally on the lateral borders of the tongue, and they're rarely found on the buccal mucosa. It's caused by the Epstein-Barr virus, and it's often asymptomatic. So treatment is considered elective. These lesions do not respond to antifungal therapy. Now, if you do want to try and treat this, or if their physician does, acyclovir is given to adults, but they tend to recur when the treatment is discontinued. Only localized treatments are recommended for HIV-infected children. And this is where you apply a topical application of podophyllin resin. And this comes from the root of the American mandrake. And it's actually very toxic. So you have to be really careful in applying this. And my feeling is if they're asymptomatic and it's not bothering them, then this probably isn't worth the risk, because it is carcinogenic and it has a number of adverse effects. You can also apply tretinoin or do surgical excision, but again, it's best just left untreated. And finally, the Kaposi sarcoma. So this is an HIV-associated neoplasm that's found in less than 2% of HIV-infected children, but it's common in adults. In fact, it's the most common intraoral malignancy associated with HIV, and it's caused by the human herpes virus 8. It's found mostly on keratinized tissues. So greater than 90% of cases are found on the hard palate, and they can appear as these red, purple macules or nodules, and they can also ulcerate. Unfortunately, there is no cure for Kaposi sarcoma. Small lesions can be treated with intralesional chemotherapy, and larger lesions are treated with radiation therapy. And this obviously would not be by the dentist. So I'm going to summarize just with sort of a protocol for treating people, children or adults that have HIV. Of course, you want to review their history to confirm what medications they're on, and be sure to look up adverse side effects and contraindications, drug-drug interactions. Look for risk of xerostomia. And also in kids, they often sweeten their medications. So you need to know what the sugar content is. And if possible, if you can get them sweetened with an artificial sweetener, that's preferred, because we don't want them to develop caries. You want to know what their CD4 T lymphocyte percent is, and if they've ever been categorized as having AIDS. And then also ask about co-infections such as hepatitis. It's critical that early treatment of the HIV infection itself be initiated in order to reduce the prevalence of these oral manifestations. And these kiddos need access to dental care at the earliest possible stage in order to prevent and treat dental disease. And so you need a lot of coordination with their physician, and also ask them about prescribing sugar-free drugs. And it's super important that you educate both the parents and the children. You know, oftentimes when we're working with kids, we just talk to their parent. But these kids are going to need to understand about their disease, how it affects their oral health, and the things that they can do to improve their oral health, especially as they grow older and become more independent. So it's good to give a periodic exam as well as dental prophylaxis every 3 to 6 months. You may need antibiotic prophylaxis, so be sure to check that their liver function is good and their ANC values, and also find out what stage their disease is at. And then regular use of fluoride gel should be considered, especially in high caries risk treatment children. Which in my opinion is all kids on these medications, but some kids' diets are very sugar filled. So you need to make sure that they have regular use of fluoride gels. So that's the end of my presentation. I've included some references for you if you want to read about this. And I'm happy to take any questions if you have any.
Thank you so much, Dr. Gonzalez. That was very informative. And thank you so much for being flexible. I interrupted you in between.
Oh, it's fine. That's good.
If you
I
have
appreciate the input.
And please remember that the recording and slides for this session will become available on our DentEcho website post-session. And I see that it's almost 1 p.m. So I would like to move on to the conclusion slides, if that's okay. Taylor, could you please share the conclusion slides?
Oh, let me stop the share. There we go.
Great. Thank you to everybody for joining us for the 20th Denteco, and also to Dr. Gonzalez and everybody for participating and putting questions and comments in the chat. We really appreciate you. Please complete the post-session survey. The link should be we will share the link in the chat shortly. And next slide. And save the date. There is a statewide dental opioid summit on May 31st from 8 to 12 p.m. Please scan the QR code that you see here, or click on the link in the chat to register for the event. And we hope to see you in 2 months in July for the next DentEco. Thank you again. Thank you, and have a great rest of the day.